Hello and welcome everyone. Today we have an incredibly interesting setup of the session. So not only are we fortunate to be hosted in Boston, Massachusetts, but we have a combined panel from a number of world famous colorectal institutions at the same time. So unashamedly, I think we at the Journal Club are very proud, and I think this lineup is as strong as any international colorectal conferences. So that is fantastic. Hello for anyone who may be watching us on YouTube. Of course, these sessions are recorded. This is our team. Of course, Dr. Galandiak is the editor-in-chief. So thank her and thank the rest of our team. The next few slides is the disclaimer and the brief description of the DCR etiquette. It's quite straightforward and standard protocol. So I tried to start with a fun fact. So the fun fact about Boston that I thought would be worth mentioning is the statue, which is called Make Way for Ducklings, based on a book by the same name by Robert McCloskey. And I haven't heard of the book actually, so I was going to buy it to my 4-year-old daughter. Perhaps when the school year is over, we usually buy something for our older kids, and she may feel missed out, so she's going to get this to read. Interestingly, the statue itself is not far from the Ether Dome, which is the oldest operating room in America and the first to use anesthesia in 1846. We also have all the crests of all the participating universities, so we're very grateful for everyone, of course. And taking a step back about the participants, Dr. Evan Masaris and Dr. James Yu have worked extensively with us to make this session take place. And so Dr. Masaris is our special guest, and we will introduce him at the later segment. Dr. Yu is an associate professor at the Harvard Medical School, Brigham and Women's Hospital. He has previously served as chief of the section of colon and rectal surgery at UCLA, as well as the chief of division of colon and rectal surgery at Tufts Medical Center. And so I would be grateful if he can come up and say a few words about the city of Boston, the different hospital networks, as well as the excellent panel that we have. Thank you very much.
Thanks, Vlad, for having us. And on behalf of all of our hosting institutions, we'd like to welcome everyone to this webinar. You know, the specialty of colorectal surgery has grown significantly in this city over the last 20 years. Most of us that are here trained here, either for our general surgery residency or for our colorectal fellowship. And for the last 7 or 8 years, we've been having these combined Boston citywide colorectal journal clubs, mostly as an excuse to get together, share a meal together, see old friends, and to make new friends. And so it was actually Evan's idea to combine our Boston Colorectal Journal Club with the DC&R Journal Club. And so we were thrilled to do this, and thanks for having us, and also congratulations to Vlad and to Susan for your great program. That picture on the left is just a picture of Boston in the summertime. I think that's the Charles River. It really does look like that. It's a great city. I think all of us really love living here and working together. And hopefully, you know, many of you on the webinar can come and visit us. The map on the right really just shows the location of the different institutions. Most of them are centered pretty closely in the city of Boston. I just wanted to say a few words about all of them in alphabetical order. So the Beth Israel Deaconess Medical Center, where I did my residency, is led by Evan Masaris, who's the chief of the division. They have a group of 6 colorectal surgeons, along with the colorectal surgery fellowships that's been active for the last 6 years. Boston Medical Center is led by Dr. Jennifer Davids. She leads a group of 3 colorectal surgeons in that institution. The legendary Leahy Clinic, the oldest program here in this region, and there's 7 faculty part of the Leahy group. Their fellowship, I learned tonight, started in 1964. So it's actually been active for 61 years, which is pretty incredible. The MGB program, so for those of you that aren't from the Boston area, you may not know this, but Brigham and Women's Hospital and the Massachusetts General Hospital recently merged into one combined academic medical center. The surgery department merged earlier this year, and as part of that reorganization, we actually created a new division of colorectal surgery. And so the inaugural chief of the division of colorectal surgery at MGB is Rocco Ricciardi. He leads a group of 17 colorectal surgeons in our network. The Brigham had its own colorectal surgery fellowship that's been active for the last 14 years. And we're really excited this year because we're expanding our fellowship from 1 fellow to 2, and those fellows will now be participating in both campuses. So we're really excited about that. Tufts Medical Center consists of 5 colorectal surgeons. It's led by Dr. Jason Hall, who's actually the chair of the Department of Surgery there, and Dr. Lillian Chen, who's the chief of the Division of Colorectal Surgery. And last but not least, the University of Massachusetts program, really built from the ground up by my friend and yours, Justin Makel. He built that program from nothing. And now it's a group of 5 faculty. They've had a fellowship for the last 13 years. Sorry, I also just didn't mention at the Leahy, it's led by the one and only Peter Marcello. So the chiefs all chose folks to present and to represent their institutions at this journal club. Dr. Cullen Roberts is going to be reviewing the article. He's one of our outstanding chief residents at Brigham and Women's Hospital. And then the discussants will discuss the paper further. And from Boston Medical Center, we have Dr. Olga Brezhneva. From the MGB program, Dr. Ron Blade. Ron is a world's expert in rectal cancer and was our chief of colorectal surgery at the Brigham prior to the merger. We have Dr. John Abelson, who's representing the Leahy Clinic. Dr. Lillian Chen, who's chief of the Division of Colorectal Surgery at Tufts. We have Dr. Kristen Kroll from the Beth Israel Deaconess Medical Center. Dr. Tess Aulette from the University of Massachusetts. And as you mentioned, our special guest is Dr. Eben Massaras. So I'll turn it over to Cullen, who's going to do the review of the Journal Club article.
Thank you very much for that. Truly an amazing panel, and we're very grateful for everyone dedicating their time. The paper that we're discussing today is called Correlation Between Grade of Clinical Response to Neoadjuvant Therapy and Oncological Outcomes in the Era of Watch and Wait. The paper is brought to us by MSK in New York, with Dr. Ronnie Rosen being the first author. The paper will be, as Dr. mentioned, will be presented by Colon Roberts, and then we will have a discussion with the panel. So thank you very much. Start when you're ready.
Perfect. So thank you, Dr. Yu, for the kind introduction. Thank you to the DC&R Journal Club for the opportunity to present and for everyone present. So for some background, in the days of Oprah, watch and wait strategy has been shown to be safe for patients with locally advanced rectal cancer who achieve a complete clinical response to neoadjuvant therapy. However, patients who achieve a near complete response have emerged as a treatment challenge. As a strict definition here, consensus has shown that these near complete responders may have a residual shallow ulcer or a minor mucosal irregularities on endoscopy, or slight restricted diffusion with major downstaging of the tumor on MRI. Data from the International Watch and Wait Database Consortium have shown equivalent organ preservation, distant metastasis-free survival, and overall survival in patients with a near complete response and complete response. However, conversely, analysis of Oprah patients according to clinical response to neoadjuvant therapy shows the opposite: higher rates of local regrowth and worse disease-free survival among those achieving just a near complete response as compared to those complete responders. So as to this study, the group from Memorial Sloan Kettering designed a retrospective cohort study from their single institution, which is a comprehensive cancer care center that we're all familiar with in New York City. Their subjects were all patients with rectal adenocarcinoma diagnosed between January of 2006 and December of 2020 who received neoadjuvant therapy. After the exclusion criteria listed below, including metastatic disease, synchronous cancers, progression, loss to follow-up, they ended with 1,230 patients to include in their trial. Their intervention was to provide patients with a complete or near complete response with the choice of active surveillance, watch and wait, or TME. The outcomes they measured were 5-year rates of local regrowth, organ preservation, disease-free survival, and overall survival. So visually, this is how they achieved their 1,230 patients. They had in their institution 1,426 patients, but after excluding 196, they ended with the following 3 groups: the incomplete responders, ICR, with 646 patients, the near complete responders with 189 patients, and the complete clinical responders with 395 patients. These last 2 groups were offered watch and wait, or TME. With regard to their patient population, there were some slight differences in the demographics. You can see here that among the group that achieved a complete clinical response, There was a difference in the distance from the anal verge with lower tumors, as well as a higher preponderance of low stage tumors, stage 1 and 2, as opposed to stage 3 at the time of diagnosis, as well as difference in the treatment modalities of that neoadjuvant therapy, with more of their patients undergoing upfront chemoradiation followed by consolidative chemotherapy. A few notes. Obviously, this was a 14-year trial. So this near complete response definition was really only recognized in 2013 at Memorial Sloan Kettering per their report. And in this study period, that is a halfway mark. Similarly, MRI only became included in their surveillance protocol at the 2013, again, halfway through their study period. And the near complete response determination at the end of the day was at the discretion of the attending surgeon responsible for the care of that patient. So obviously some degree of subjectivity. For results, what they found was that looking at the left panel, comparing the near complete responders in red to the complete clinical responders in blue, the near complete responders had higher rates of local regrowth. When comparing all three groups, the complete clinical responders in green in the middle and right panels, the near complete responders in blue in the middle and right panels, and the incomplete responders in red in the middle and right panels, they did find a difference in the 5-year survival, disease-free survival rates, with the near complete responders having an intermediate result, worse than the complete responders, but better than the incomplete responders. Though this effect disappeared at the 10-year mark, perhaps in part due to small numbers that had made it to that stage of surveillance. Additionally, there was no difference in overall survival between any of the three groups. Of the complete response group, 89% entered watch and wait, 11% electing for TME at the time of diagnosis. The 5-year TME-free survival rate in these complete responders was 68% overall, which represented 73% of the watch and wait group. And the 5-year disease-free and overall survival rates were 82% and 90%. Of the near complete response group, 43% entered watch and wait, and their 5-year TME-free survival rate was 28% in the overall group of near complete responders, representing 53% of the watch and wait group. The 5-year disease-free survival was worse than in the complete responders, with 73% of the near complete responders having disease-free survival at 5 years compared to 82% in the complete clinical responders. However, overall survival was not worse, 86% to 90%. The near complete responders who did receive upfront TME, interestingly, had improved 5-year disease-free survival at 86% compared to just 55% of those who entered watch and wait, as well as improved overall survival with the upfront TME achieving an overall survival rate of 92% at 5 years compared to the 78% of the cohort of near complete responders who entered watch and wait. However, the converse of this is that 35% of those patients who had a clinical near complete response and underwent TMA were on pathology ultimately determined to have had a complete pathologic response. So as you can tell from these data, overtreatment and undertreatment remain common in these groups, highlighting a significant need to better recognize patients who have attained a true and durable complete response. For limitations of the study, it was a retrospective study at a single institution. There was a heterogeneity of neoadjuvant treatment regimens as well as surveillance techniques. And again, there was inherent subjectivity in determining the completeness of response. Additionally, the changing standard of care in the 14-year study period makes the results somewhat hard to interpret. In conclusion, in this cohort, clinical response to neoadjuvant therapy was associated with improved oncologic outcomes in patients undergoing watch and wait, with near complete responding patients achieving intermediate oncologic outcomes, worse than the complete responding patients, but better than the incomplete responding patients. This effect, though, was not seen in long-term survival metrics, which were identical among the three groups. Of those patients who converted from a near complete response to a complete clinical response, we were still able to achieve high rates of organ preservation, though also with higher local regrowth rates. So questions that this study brought to mind that I'd love to hear the opinion of our excellent panel is, what rectal cancer neoadjuvant therapy regimens are used in the practices at our institutions across the city of Boston? And how do we counsel our rectal cancer patients regarding watch and wait versus TME in light of OPRA and these results? Do our recommendations differ based on our perceived need for an LAR versus an APR for the patient in question? And has the advent of transanal TME impacted our practice and counseling in any way? In addition, I'd like to hear insight and everyone else's take on the article, because as we've heard, we have such a wonderful panel, and begin with our special guest, Dr. Masaris.
Thank you, Dr. Roberts. We'll leave the special guest segment for now. Now, those questions were fantastic, and I think that is an excellent way to start. I was hoping that perhaps either Dr. Yu or Dr. Masaris will be in charge of the microphone and can then share it around in the room. Obviously, you're way more familiar with who has strong opinions on which particular question. But yeah, let's start with that first question, which was great. What rectal cancer neoadjuvant therapy is used in Boston? Is it a uniform algorithm, or does every colorectal department have their own approach?
So, Vlad, I'm going to start that. I'm sure not every colorectal department has the same, but we would appreciate if you could put the questions up so we can all see them. So, first one is, what rectal cancer neoadjuvant therapy do we use in our practice? Do you have any first speaker, or should I give it to Dr. Blede from the Brigham?
Well, going through these questions, first of all, excellent presentation, Colin. So we don't have one uniform neoadjuvant therapy. It depends on the patient when they come in. We try to put chemoradiation up front with consolidative chemotherapy for patients that need sphincter preservation with chemoradiation being their only option. If it's growing into the levators or into the anus, we try to maximize the complete response chance, which is a little higher if you put the chemoradiation first. If it's a mid or upper rectal cancer, it's less of an issue. We find that if there's a lot of lymph nodes and a mid or upper rectal cancer, we flip it around and give the inductive chemotherapy first. I think that that's an important point to make about all this. I get concerned when I look at the results is that they kind of say, well, if you don't look at the overall survival, don't look over here, don't look at the DDC for survival in patients who have near complete response. I know it's a little worse when you do watch and wait, but it's if you just give them more time. Of course, you don't know who to give more time to. So I would say is we push the envelope on watch and wait for patients where they're likely going to need an APR, and we are more aggressive, particularly with the upper rectal cancers, that even when they get a complete response, we discuss whether we want to still go ahead with a low anterior resection. With the incomplete responses, a last point is that we need to standardize how we assess an incomplete response. It's really with flex sig and MRI right now, but let's say you have a unequivocal MRI, but equivocal flex sig or vice versa. Then we get into a really unclear sort of future as to what to recommend to that patient. So I think that we need more data on those two modalities to see which is the better of the two to believe. So
Thank you. Just to follow on that, I kind of thought that originally it's either complete pathological response or incomplete, and if it's incomplete, you then offer surgery. This near complete really has stuffed up my personal algorithm, and with that, I wonder if there is now a role for transanal excision in near complete pathological response to know if there is any cancer there, because clinically it's very hard to tell. Do you use local excisions in this setting, or would you consider it at all?
yeah, if it gets down to the size of a pencil eraser and the MRI is unequivocally negative, yeah, we do consider it. Post chemoradiation, the healing is a little bit unpredictable, and it's not as sort of slam dunk as a person who doesn't have chemoradiation, but it is considered. It's pretty rare that we get to that point. We usually give them more time, and if they're still unclear after 8 weeks and then 12 weeks and then 16 weeks, we usually then, most of us will make a decision one way or the other and usually that's for surgery if they remain sort of unclear at 16 or 20 weeks time.
Do you have an absolute cutoff? Is it the 20 weeks where there's a line in the sand?
No.
That's an absolute cutoff. No. I'm going to hear now from UMass, Dr. Olet.
Thank you. Great presentation. I would kind of echo what Dr. Blede said. We do not have a standardized approach for all of these patients. Discussion at tumor board often comes down to a lot of the patient characteristics. For patients who are symptomatic, lower tumors where we're hoping to achieve a clinical complete response, will often start with the chemoradiation. If there's concern for, lymph nodes or systemic disease, might start with the induction chemotherapy. Sometimes, I was very excited about this paper. I have several patients where I'm in this conundrum of the near complete response. I think for a lot of these decisions, having the information, the data to be able to have those informed conversations with patients, and a lot of it does come down to sometimes what the patient wants as well and what risks and what they are willing to accept, especially when we're talking about tumors that are going to be an APR. We're seeing younger and younger patients with these cancers, locally advanced cancers. And so, I have had patients where it's this doesn't make me feel super comfortable. It's not a classic white scar that I'm going to feel super comfortable offering the watch and wait, but it's that pencil head, and I've taken for local excision. I think the thing that this paper really highlights is, again, we don't have great tools at identifying patients who have a pathologic complete response. We're still not good at identifying and stratifying patients. And so, as a clinician, to say you have to have an APR and then you're going to have a complete pathologic response, is hard to sometimes convince patients to really want to undertake that next step. So I have been using transanal excision to gain additional information to help counsel the patients. And so I think this paper does offer, again, additional data to help kind of inform those conversations.
Thank you. Can I just follow up on that? Now, in my mind, it makes sense if the cancer is within finger reach that's an effective way of doing clinical surveillance. Particularly in some of the international centers or where I work, endoscopy may be limited in an outpatient format, so you can only do it in the operating room, which then adds an extra layer of logistical challenges to regular surveillance. But if I flip the question, how high up the rectum would you consider watch and wait? Where is your cutoff from that perspective?
Yes. I haven't had a ton of patients in that kind of upper. My fingers are 6 centimeters. So I have a little bit of a shorter distance where, is it fair that my fingers are shorter than maybe yours? So my patients aren't going to get the watch and wait. No, but I do think I will still offer patients if I can't feel, but, are going to definitely have maybe closer endoscopic and MRI surveillance. I think the other thing, one point in the paper is that they identified there were a few patients who had, regrowth that was only detected by MRI and, one that was only detected on PET scan. They didn't really go into, what was the DRE on those patients, right? If MRI was detecting it, but we weren't detecting it with the FlexSig or the DRE, right? Even we might not be perfect with our FlexSig and our DRE. So I think it is really important to take all of the pieces, and not one thing is 100% sensitive.
Thank you. I have short fingers too, and so perhaps for the CPG guidelines, we should have a statement where a surgeon with short fingers and a patient with big buttocks should never be in the same room together.
That's great, Vlad. BMC, Dr. Beresnova.
Thank you. Great presentation and great paper, and so timely. I've also been struggling, kind of offering and counseling patients with this problem when I see them in clinic. So as this paper demonstrates, we as physicians are not that great at actually, detecting when cancer is there, because over 30% of people in clinically complete response still had pathological cancer for the patients who were resected, right? Or, on the other hand, when patients had resection for incomplete clinical response, complete pathologic response was found, I believe, in 22%, right? So definitely this is something that where we can improve, I believe. So sometimes I started employing PET scan. I'm wondering if anybody else in the room does that. And if yes, why? And if no, why? I feel like this is just an additional point, a piece of a puzzle. And I'm curious what other things about that.
Thank you so much. I'm going to answer for the BI that we do not use PET scan. Surprised nobody brought up circulating DNA, which would be another conversation which is coming down the road. So next is Dr. Kroll from BI.
Hello. Are we still discussing the first question, or are we just discussing the article? The first question, which is, who are we doing TNT and how? Yes? Okay. I just wanted to make sure, because I think every place is a little different. And I think we've noticed that over our journal clubs over the years that I've at least been in Boston, that every place is a little different. I think everybody in the Boston area is using long course radiation. And then we're varying our TNT approach based upon clinical factors. And that's what we're doing at Beth Israel. And so our most common approach is, just as Dr. Blade said, chemoradiation up front, chemotherapy secondarily. I think we are looking a little bit more into EMVI positive tumors and sometimes doing chemotherapy up front more on those cancers. But I think we are a bit more strict at Beth Israel unless the tumor is involving the peritoneal reflection. Unless we know we can get the small bowel away from the upper rectal cancer, we're doing more upfront surgery on our upper rectal cancer rather than neoadjuvant therapy, or doing just chemotherapy up front so we don't risk the injury to any of the small bowel.
Thank you. I have a question sort of in relation to the International Watch and Wait database. So that's been around for, I think, since 2014. And in the meantime, there's so many different permutations of what we do. And patients have now had the benefit of seeing what worked, and we have both the curse and the benefit of seeing complications of that. My concern and question is, have you seen patients who have a recurrence or have some sort of complication, and have you got challenges related to seeing what was the thinking behind them starting their treatment? And are you comfortable understanding what was the treatment then and what can be done now? Or is it just a bit of a mess?
Yeah, I think it depends on where the patient's treated. If they're treated with us, and then we kind of know the thought process and have a hopefully documented plan. I hope I'm answering the question correctly, which is from y'all's response, I think I understood that we don't really know the upfront thinking, but I think with all of us in Tumor Board, we try to document our upfront plans, why we're choosing what we're choosing, what's the data and thought process behind it, and the multidisciplinary discussion with the radiation and medical oncologist. If they don't have a great response or they have recurrence, then hopefully we have the appropriate imaging follow-up to be able to catch it early. Did I answer that?
Yeah, I'm sorry. I think this is my fault. I didn't phrase my question eloquently. So I think if we have the standard of care, that's very much reproducible. But when we have the X factor being patient-specific care or patient-centered care or whatever appealing acronym we might use, that becomes a lot more gray. And my concern is, can we still offer reproducibility like we do in the operating room when we focus on patient-centered outcomes which are unique for that specific patient?
I think I will defer to my colleague here who is working on a decision aid for rectal cancer patients and working on informing patients of their potential outcomes as well as their potential complications.
Thanks, Kristen. This is John Abelson from Leahy Clinic. Yeah, Vlad, I think it's very important to consider where the patient's coming from, because I do think that the treatment that you offer will be dictated by that patient and just how frail they may be or their underlying functional consequences of what radiation would do or surgery would do. If a patient's starting out with 5 liquid bowel movements a day and daily incontinence, I'd be less worried about saying we should probably be doing an APR and not avoiding, and saying we're going to choose organ preservation. So I don't think it's a one size fits all. I totally hear you about the heterogeneity that exists with how we treat patients. You mentioned the International Watch and Wait database. We do have our US experience that we've added to literature that we published in DCR, led by John Vogel out in Colorado. And so I think that's another useful data point to come to, because a lot of the international groups were using just chemoradiation therapy, whereas US is using a lot of total neoadjuvant therapy. And so, but ultimately, I think that you'll find that the results are quite similar. I think one point that I'll make just regarding the tumor height. So even within our group, we have a lot of, not just like this group here, but our group at Leahy, we have a lot of debate about whether or not it's safe and appropriate to be offering watch and wait for upper rectal cancers. And so one of us says, absolutely not. That's not the way that the trials were done. It's not in the guidelines. And then some of us do offer it. And I think in part to Tessa's point or Olga's point about how long your finger is. And I think, that there is a lot of value in flexible sigmoidoscopies. We like to use a biopsy forceps as a extension of the finger to poke and prod the scar and see if there's any raised elements or seeing if it bleeds or moves. And so we try to use that as an additional data point.
Thank you. Can I just push you a little bit more on that research that you're doing? So I think there's an element of so-called surgical psychology in decision making. And in rectal cancer, in my understanding, there's a spectrum where on one end of the spectrum, we have patients that want absolute cure at any cost. They may have 3 kids under 4, say, and they just want to be around. And on the other spectrum, you have patients that want to keep their rectum at any cost from a quality of life perspective. As a surgeon, how much impact do you think you have on swaying that patient?
I don't know that I would say that my role as a surgeon is to sway them one way or another. I would say that my role is to educate them and teach them about what the risks and benefits are of all of the different options, and to tell them, what my recommendation may be. Now, oftentimes in these situations, they may ask you, what would you do if this was your husband, your wife, your daughter, your son? And I will, in those situations, for sure say, well, obviously that depends on my own wishes. In my situation, this is what I would choose. But I do think you're right to a degree where it's how do you really, I mean, we train for years and years and years to be able to understand all of the data and understand all of the science. And so how can you really take some person off the street and expect that they're going to be able to make a nuanced decision like that when we have all this training? So I don't think that it's just the patient making the decision. I don't think it's just the surgeon making the decision. I think we're there to educate.
Thank you. So the follow-up question to that, sorry, one last thing. The follow-up question to that is, do you think there is inherent bias in the patients that present to institutions like MSK or like, some of the named places in Boston where you guys work, where you ultimately, not yourself, but the patients then self-select the pathway that then gets them into these big publications?
Yeah, 100%. And I think it goes the other way too, where there are centers where it's not offered at all. And so, I think that there is some concern from surgeons to talk about the option of watch and wait at the first visit. But I think the reality is our patients will become more and more nuanced in terms of their understanding of the disease. And so I think if you're not talking about all of the options and they can easily find it on any searchable platform or with AI, then they might then come back to you and say, how come you didn't talk to me about this?
Thank you.
Around from the beginning again.
Great. So we're kind of skirting from one question to the other. I'm sorry if it makes it a bit more confusing, but at the same time, I'd like to kind of have a stimulating discussion. So I guess the second question is focused on counseling rectal cancer patients, and I think that that's a good transition from what John was answering. And so I guess in relation to counseling between watch and wait and TME, how do you do that? And interestingly, do you mention the potential local recurrence rate of TME? Because we all focus on the regrowth rate in watch and wait, but I wonder if there's a balance in highlighting the complications of both.
Vlad, the question is, if the patient has gotten TNT or some kind of neoadjuvant therapy and there is complete response, or is it for all comers? Because if it's complete response, that's your question?
I guess it's for all comers. Yeah, if it's a complete clinical response, obviously it's a little bit of an easier decision.
I thought we had a patient guidance and decision making here. So we still offer both, by the way. But I'll have Dr. Blade answer the question from the Brigham.
What we've not talked about is the sort of the new therapy in the room, which is the prospect trial, which we're big fans of, quite frankly, for the mid and upper rectal cancers. And so I think we're narrowing the TNT discussion, at least at our institution, down to those patients with threatened margins on the mesorectal fascia and those with threatened sphincters down in the anal area. Anything mid to upper is either, as mentioned before, if it's very far upper and you're not sure it's a sigmoid, you take it out, or you give them 3 months of the chemotherapy per prospect trial. To make it even more confusing, they used to be our cousins, now they're our siblings over at Mass General, go and do FOLFIRINOX while we over here in this town do FOLFOX. And so it gets even more sort of confusing and nuanced. But I think the main thing is that we do these discussions about TME and TNT with that group of patients with threatened margins and anal sphincter issues. And what I do, the only time it is John talked about a little bit, where I put a little bit more of my own opinion into the mix, is the person who goes, if I don't have a complete response and I need a colostomy, I'd rather die. I say, you don't want to die that way. It is a horrible death, and I paint the stories of, and so that's the only time I put my foot on the scale, is in that situation. So again, we're getting more and more narrow as to what the TNT and what the watch and wait issues are there's fewer and fewer, I think, patients in the mix for that, in our opinion, and for that particular conversation.
Thank you. We'll move on to UMass.
Yeah, I agree. I think in terms of the discussion with local recurrence TME, what patients were doing, the kind of upper rectal cancers. I would agree. I think Dr. Kroll kind of also alluded to this. We'll often do upfront surgery for those patients. This is one of the things that our group is actively looking at. We were very curious as to, for these patients where you can't feel the tumor, should we be offering those? And so that is something that we are looking at in our experience. I think, again, the patient's input is critically important. And we are, again, depending on their functional outcomes, might go for these upper cancers, go straight to surgery for these patients. Like Dr. Blade had mentioned, we are also, in terms of deciding at tumor board, if it is straddling the peritoneal reflection, if it is, we're concerned about the margins being threatened, is when we might be offering the upfront TNT.
Vlad, I think Boston is together on this thing. You need to be more controversial. Do you have
thank you.
follow-up question, or
What
you want to go down?
I think we're probably good for this question. I guess looking at the third question, looking at APR first, what is currently the standard of care for APR? Let me rephrase. What is the standard of care for patients who require an APR? Is it still surgery first, or are we at a point where obviously if a patient is fit enough, etc., but the default would be potentially offering curative chemoradiation and a watch and wait protocol and only do the APR as a salvage procedure? Are we there yet or not?
But I need to spice it up a little bit, okay? So I want to put a scenario down. The patient needs an APR on presentation. Patient gets neoadjuvant therapy because that's what most people give in Boston. And now there's still a remaining cancer, but you can do an LAR. Do you do an APR or do you do an LAR? I'll start with BMC.
Thank you. Tricky question, right? Okay, it comes down to the patient, right? And the discussion of what this potentially could entail in terms of recurrence if you do end up salvaging the anus. When I discuss this with my patients, I definitely discuss that, if since the tumor was invading or abutting the anus and we're preserving the anus, then there is a high chance of recurrence. So, I usually would counsel them on an APR to prevent the recurrence or minimize the risk of that. However, I understand that there are patients who would like to have the continuity, GI tract continuity, and preserve the anus. And then if they choose to keep the anus and if they together, I guess, if we choose to perform LAR, I would offer them that option.
Again, I'm just poking I would do what Dr. Beresnev just said, but I like how we dump it on the patient when things get tricky, and otherwise we do it how we want it. I'll go with Dr. Kroll from BI.
Vlad, I think you didn't ask this question because your answer is straightforward from our training. If the patient needed an APR, the patient still needs an APR. That is my personal recommendation. That is not always the recommendation of BI, because there were a lot of studies showing that regression can then be sphincter reserving with chemoradiotherapy. So I think that's provider specific of how they're going to counsel the patient. But I wouldn't offer a patient who needed an APR up front, especially if the levator was involved or the anal sphincters were ever involved, that they should not be offered only an APR.
Dr. Tracy Hall is retired, but her spirit is still around. I can see it here. Dr.
We just have to speak loudly.
If I may, I wanted to can I change topics? Well, just one comment that I wanted to make just about, it's not really changing topics actually at all, but so the use of circulating tumor DNA in these near complete responders, is anybody using it? No.
Our oncologist is really fond of circulating tumor DNA, but when it comes to surgical planning, we don't really use that into consideration just because we don't know how to use it just yet, at least.
I guess Dr. Wilson has the answers. Go ahead.
I do not have the answer. We're not using it at Leahy right now. I mentioned some of the work that John Vogel is doing at University of Colorado, and as part of that ongoing group, we are talking about doing a trial to try to answer that question. I know that there are several centers who do use it routinely for rectal cancer, and use that to help guide decision making. NCCN guidelines do not support that, but I think it's reasonable. And so if we come full circle back to that paper and we talk about those near complete responders, to me, I think that would be a great role for circulating tumor DNA, or potentially even the PET scan, which, going back to your question, Olga, no, we don't use PET scan in that situation.
Our brothers and sisters up the street, they do have an MR PET scan, which in this, it may not have a lot of uses, but this is one of them where it may be extremely useful. It's really not ready for, I'd say, mass sort of use, but I think that's one thing where I would like to see the future of that in these incomplete response questions, for these incomplete response questions. To circulating DNA, you have to have 2 negative circulating DNAs for instance, your stage 2 cancer, and are you going to get postoperative chemotherapy? A lot of the oncologists, if they feel that they're on the fence on whether to give it or not, will use circulating DNA in that situation, or with a stage 3 colon cancer where they don't want to give it. But we have to remember, it's not just one, you have to have 2 in order to feel confident that it works. Finally, to your 4th question before it comes around again, we do not use TATME. We tried it. We found, quite frankly, patient's function was pretty bad afterwards, and it was only useful for a small subset of patients if they had it in the mid-rectal cancers. And so we tried it, said thank you, and moved on.
Can I just ask, sorry, I think the circulating tumor DNA is obviously very topical, and it's going to get bigger, and it's going to cause us more debate. But my question is back to sort of surgical psychology. Do we have a difference where we've gone from clearly looking for either cure or palliation? Arguably, that was Tracy's Hull argument for doing an APR on original staging. Have we gone to now aiming at cancer as a chronic disease, and we're using different modalities to suppress this disease as far as possible? And as such, is knowing tumor DNA convert us from thinking of an intervention as a for cure intervention to then looking at things from a how do we palliate the patient as best we can?
So Vlad, in order to give a break to all the speakers, I'll get Dr. Yu to answer this.
I mean, I still think of treating in terms of cure. I mean, I think you're thinking about a palliative situation. That's a totally different conversation to have. But I mean, I'm not thinking about it in that way.
I mean, I'm not saying active palliation here, but if you give adjuvant chemotherapy for someone with metastatic disease, hypothetically, that's a palliative treatment. We're not thinking they're going to die straight away, but we also are not that confident that they'll reach cure with that modality.
Yeah, I agree. I just think in the context of whether you're going to operate for a complete response or not. I mean, I think, for example, in the setting of metastatic disease, that would, you wouldn't even consider that, right? So I guess I just view them as separate situations.
I guess if you have tumor DNA, though, which is elevated, do you then view this as patient with, who is still able to be cured or not?
Maybe that patient is, now I'm interfering because I want to comment, but maybe that patient is the 11% that's going to develop metastatic disease and nothing on the local, correct? So that's number one. But Doctor, you said something, just bypassed it easily. Oh, and I forgot what you just, he said, well, if you have metastatic disease, there's no role for Watson weight. I'm gonna, okay, sorry. Yeah, okay. So maybe the opposite. I think we agree then that we have patients that have metastatic disease, they have complete response, and we don't go out for the primary. We leave the primary in, meaning, the scar of the primary, I should be specific, and we go after the metastatic disease. And they actually perform, some of them will perform well, but of course, everything is biology. All the paper that you just described is biology. If you respond to the treatment, you do well. If you don't respond to the treatment, you do not do well. I think that's the rule that still stands.
Well, in that case, can I just ask another scenario? If you have a complete clinical response, but on your follow-up surveillance, you find that the pelvic sidewall seems to be concerning for disease, and then we can talk about PET scan or MRI or whatnot. What do you do in that patient, in that you think that they responded locally, but at the same time, you're concerned that they have local recurrence?
It depends on if it's resectable, because if they are continuing to have nodes higher and higher up, then I worry that a surgery and a break from treatment is going to continue that nodal spread more proximal. And so we'll discuss in tumor board continuing chemotherapy for these patients, or seeing if we can do an iliac lymph node dissection depending on where it is. But these are the patients that I personally worry about having continued nodal spread up the aorta cable nodes, and then supraclavicular nodes with a breaking chemotherapy.
So Vlad, I'll share one of the fun things about training in this area is that every month fellows have a teleconference that they participate in that rotates among all the different sites in terms of what topic we're presenting, who's presenting. And this past week, there was a patient presented with that exact same scenario, Vlad, where they had clinical complete response and then they had recurrence in the pelvic side, pelvic lymph nodes. And we had a very interesting discussion about what you would do. And I would say our response and thought from Leahy was that that patient gets surgery and a lateral pelvic lymph node dissection. But there was a suggestion that perhaps that patient just gets a lateral pelvic lymph node dissection and gets to keep their rectum.
Thank you. If I learned from anything from training in America is that there is no such thing as not resectable. Everything's resectable.
Just to counter-argue this, we're surprised with the amount of side effects that we see on people that have a complete response and get total neoadjuvant therapy, have a complete response. And till now, I thought all the sexual dysfunction is attributed to my LAR. But now we're finding out that patients that get radiation actually are not as happy as I thought they would be after a complete response. I would be jumping around, but the quality of life is not as great as advertised.
Thank you. I've noticed similar. I've actually noticed, and maybe it's a background of patient to begin with, but I've noticed some pelvic outlet dysfunction in patients, in particular levator spasm, which is really hard to treat. Again, I'm not sure how much of it is a psychological trigger because of cancer, but it seems related to radiation. For me, at least, that's a way to blame our colleagues.
Everybody's nodding in the room, and we will all wait for Dr. Abelson's study to tell us what's happening with that.
Well, thank you all very much for this component. I am trying to maintain the time, and it's almost on the hour. I was hoping to move on and sort of focus on Dr. Masaris as the special guest segment. And so Dr. Masaris is the chief in the Division of Colon Rectal Surgery at the Beth Israel Deaconess Medical Center, which is one of the Harvard Teaching School affiliated hospitals. He's actually been with us before, and we featured his work with the DCR Journal, where he is the curriculum director for the Reviewers Guild. But one of the things we tried to organize beforehand for today's session is to sort of talk about the present and future direction of database research. And I think it's particularly topical given that there are so many affluent institutions in a very close geographical space. And so I would assume collaboration is something that would be quite efficient in Boston. So to progress with that, I was hoping to start with the following question. So what is the role of hospital-based database research? Specifically, what are some examples of surgical questions that may motivate you to pursue that form of research versus a RCT or more national-based databases, etc.?
So you're talking about a study that, like the paper you presented, that was just presented, which
Correct.
is from MSK, and it shows the data from a local institution. I think there is a role for this. I think pragmatic data of everyday life with decision-making made by the physicians or the tumor board in, real life, and then seeing the outcomes afterwards is important. I think local institutions have more granular data than any national database, including the international database for Watson Wade or the American database for Watson Wade, which are both great, but they don't drill down to the new questions that have come up now about, who recurs or who is not a complete responder. So there is a role for, I think, institutional data and institutional databases, and it is for studies that need to go down to the most granular data. In rectal cancer, the MSK study is an example. If you want to do a study about truly near complete responders and truly the cause of death of the patient, whether it was tumor related or not, you unfortunately have to go to institutional data.
Thank you very much. And just for those who may be listening to us, can you compare and contrast local databases compared to something like NestQuip? When and why would you prefer NestQuip over a hospital data set?
Yeah, I mean, NISQIP is a great database, and especially if you have the targeted colectomy, proctectomy file, you have even the oncologic markers of the patient stage, treatment, when did the patient receive the treatment. Still, that database does not have the granularity that an institutional database would have. So I would go to NISQIP if I'm looking for a more generic idea, for example, whether an anastomotic leak is associated with neoadjuvant radiation therapy. That will never be proven institutionally. You need thousands of patients to prove that. NISQIP provides the thousands of patients. Now, things are changing. I recently found out, and this is for Dr. Abelson, it's my present to him, that if you're in the system and you get IRB approval from one hospital, I'm talking about the BLA system, you can use data from EPIC and from all the institutions, and you don't need special approval. So same thing with MGB. You can use the data. So what I mean by that, suddenly you have hospital systems with 20, 25 hospitals, or in California with 200 hospitals or 300 hospitals, that you can gather the data very fast. And suddenly it's not institution database, it's a system database, which is something between NISQIP and one institution. It just gives you the granularity of the institution level, but also the gravity of having thousands of patients in your database. So I think that's where things are heading, as long as the systems continue to invest into using the data from EMR and how to retrieve that data.
Thank you. Just following on sort of the collaboration between hospitals, if you're, say, you're doing a study and you're using intra-hospital databases, say most of the Boston hospitals, for instance, and then you come across a homogeneous population and the results are similar and life is good. Fantastic. And then you do another study and you come across and you see that the clinical outcomes have significant disparity between the institutions that you're investigating. Now, this happens, I guess, from time to time. How do you navigate that politically from a practical perspective if your hospital is up or down compared to your neighbors across the road?
Oh, you're talking about politics here. So I'll start with, in regards to NISQIP, there's a group of all the hospitals in the state, compare their outcomes every day in a de-identified fashion. So this is simple outcomes. I'm not talking about research or anything like that, because you want to know where you stand. So when you get that database, it says, for example, that BI, which I represent, is like 10th out of 10 institutions in anastomotic leak. So it's the worst of all. I don't know what the other institutions are, but I know I'm 10th. I need to do better. So that's quality improvement. In regards to research, there is a problem, I think, and this problem has to somehow be challenged and changed. And that is, if Dr. Blede wants to do a study with a BI, he needs to get 500 approvals from the Brigham, 500 approvals from the BI to share the data. It should be easier. And I say that because if you de-identify the data, it's the same data that we give to NISQIP and we give nationally in non-secure databases, actually. So there should be a better way for inter-hospital from different systems to work. I think the inter-hospital within the same system, we have worked it out. Now, in regards to the difference in the outcomes, not politically, but you could have, I'll give you an example, a high volume rectal cancer program that probably has better outcomes than a low volume in the same system. And you're trying to do an analysis, and obviously there's a disparity. There are statistical methods that you can, let's say, equilibrate or do an analysis, sensitivity analysis, to alleviate these differences between the institutions, or even between surgeons within the same institution. If you have 17 surgeons and one has a CRM positivity of 20% and the other one of 1%, and everybody else in between, those are the outliers. There are statistical ways to try to accommodate for those.
Thank you. I think that's certainly, I think that's incredibly useful for people starting out. doing complex research studies. Now, my next question is sort of about the digital world. So one of the obvious benefits of the digital medical record is that you can use large language models to tabulate data. But I do wonder if that impacts on the future of database maintenance. Obviously, maintaining a database is costly. Analog sort of input into databases has its limitations. Do you think that the days for analog database management is numbered, or will it continue?
I think it won't continue. I think the way we're going in the next probably year, there is going to be software that will withdraw the data from big electronic medical records and have all the data that you need on hand. Right now, Epic, which most of the institutions use here, can scan through everything and gather. Even if you try to hide a stomatic leak, it will pick it up. You might say infected hematoma, it will pick it up. And if you don't say anything, it will pick up the culture from the drain or the antibiotic that you gave, and it's got to be more reliable. And it's very easy and it's very fast. So I think the delay is in the Epic software getting the AI that's needed to run things. I know they have it actually, but that's where it's going to be. And I think traditional Excel database that everybody has, or a RedCap database they have in their cloud with the rectal cancer patients is going to be useless. You will say rectal cancer patients 2011 to 2014, what treatment they received, and all that, and everything's going to be given to you in an Excel type of format automatically without you having to retrieve from something specific.
Thank you. I guess with the automation, one of concerns that some people have would be the legal and ethical risks with this data. Being a researcher yourself, have you noticed any difference in terms of how data is protected or how ethical departments are interrogating innocent clinicians in making sure that that is better optimized now than previously?
I don't know exactly if I understand your question, but I can tell you, I'll start with an example. I think it was 3 or 4 years ago, Dr. Kroll, who's here, walked in my office and says, I need the chief's letter for a grant that I'm submitting tomorrow. So I said, don't worry, ChatGPT will do it for me. So ChatGPT did it 4 years ago or whenever it came out. And it gave, literally the letter was the best letter. I thought, this is going to get the grant just because of this letter. And we figured out very fast that the citations that it had put that were perfect citations, it was like some kind of Crohn's grant, yeah, were not hers. She had not written the papers that that were in the letter. And then we went into the journals. Actually, those articles did not exist. So those are, I think, the early days of AI. Of course, things have evolved. This doesn't happen anymore. But I talk about Dr. Abelson retrieving data for our rectal cancers, which he can do. The AI will never pick up the culture and the thought process behind making a decision for that rectal cancer patient. That's where the human factor is needed. So for Dr. Abelson to be able to decode what happened to our rectal cancers and why we treated them differently than what the Brigham did or the Leahy did, somebody from a human has to check the data and validate the data. Sampling or something like that to give an idea of, okay, why at Leahy, at T3, N0, M0, mid-rectal cancer gets TNT, and the Brigham, it gets just chemoradiation. And that, the AI cannot figure it out. And if you train the model, it's just going to spit the same answer again and again and again if you train it a specific way. But that's not the way you want it. You want to identify the differences. And that's where the humans come along. So you use the AI to get the data, and then use the human to take away all your ethical or other concerns you might have in regards to like the illusion that the AI could cause or the manipulation. Whatever you feed it, it's going to pull it out, correct, as a result. The key is if you scrutinize what you're feeding in the model.
Thank you. Just one follow-up question with that. I guess I used to think that surgeons or academics that have a advanced understanding of statistics have a sort of inherent advantage in doing academic research. Now, with the development of AI, do you think that surgeons would benefit more, or not even more, should be well versed in understanding coding and kind of understanding what is under the hood when it comes to using large language models, for instance, to further their, whether it's writing letters or further their research ambitions.
I think whoever's in this room, it's too late. I don't think anybody's doing coding right now, and I don't think we're at the level we're going to learn coding. I do think that coders will be like knowing basic statistics made a difference for us at the time. Same thing is knowing basic coding. Now it's for the generation that's coming out of medical school. Will help you. I don't care how good you are at using the AI. It will never produce exactly the code that you need. You're going to need to adjust it to get the actual result that you're looking for. It will make it faster, correct? Like for us to do a statistical analysis, it took us 24 hours. I have stayed in the past, we're talking about like 20 years ago, numerous nights up doing statistics. Now you just click 3 times, you give the instruction, and it gives it out. However, still you need that human input, at least for now, to try to get the result that you are thinking of. Just doing a regression analysis with all the data is not the answer. So you have to work with a model, and you can run the code, but you need small adjustments that, unfortunately, if you don't know coding, you cannot still do on your own completely.
Well, thank you very much. I think this is just a quick sample into sort of that field, but hopefully that may stimulate some thought for people who are watching our recordings. Of course, we also send out little tidbits of questions and answers on social media like Twitter and the like, so some of the questions will be available there. Generally, I'd like to thank everyone for your support of the Journal Club, for attending and answering and providing some fantastic opinions. I think I certainly learned a lot, so thank you all very much, and I hope you enjoy the rest of your evening and your meals, and see you at the next Ask Us conference.
Taris, Margaret, Stephen, Vlad, thank you so much. Dr. Hugh just stepped out, but we need to thank him for getting us all together. And I want to thank everybody that contributed to this. It was a very good experience, I think, for all of us, and I hope we learned something. Thank you so much.
Bye-bye.
Bye.